Right, dear class, those two topics on endocrine that we will cover today, we'll need a review from you guys of the hypothalamic pituitary gonadal axis in order to better understand how the male and female gonadal hormones are secreted and regulated. I'll do my best to provide some essential basics on the physiology of this topic to help you understand the use of those hormones for female and male. So let's get started looking at this slide where it says that, and you can observe here on the top, hypothalamic axis with the anterior pituitary. And the hypothalamus has this only single hormone, which is the gonadotropin releasing hormone, that controls the synthesis and the release of both gonadotropins, which is the LH, luteinizing hormone, and the follicle stimulating hormone in males and females. You also observe that those hormones will be targeting the tissues, which is going to be the gonads in the male, the testes in the woman, the ovaries. As you can see, the gonadal steroid hormones, which are basically estrogens, androgens, and progesterone, they also exhibit a feedback, a negative and positive feedback, as we see here, at the level of the pituitary, anterior pituitary, as well as the level of the hypothalamus. We also see that there is a protein called inhibin, which is produced by the target tissue and has specific effect inhibiting the FSH, but not the LH secretion by the anterior pituitary. And another thing to call attention here in this slide as well is the fact that there is also another hormone, which is the human chorionic gonadotropin, HCG, that is synthesized in the placenta and has its effect by binding to luteinizing hormones receptors. You see here that LH and FSH have effects on a woman and a man. In the woman, LH has the effect of stimulate the synthesis of androstenedione and its precursor of estradiol, and also has the effect on the rupture of the mature ovule in the synthesis of the progesterone by the corpus luteum. In the man, LH has the effect on the testicular Leydig cells to stimulate the synthesis of testosterone, which is the main gonadal hormone in man. And the FSH in woman, as the name says, is a follicle stimulating hormone and also has an activity over aromatase with the production of the 7-beta estradiol. In men, FSH has the effect of stimulate the Sertoli cells to produce nutrients that will allow the sperm maturation. So let's move along. So let's start talking on the uses and indications of the gonadotropin releasing hormone, which is the hormone synthesized and released by the hypothalamus. So the GnRH, as is known, acronym, has a diagnostic indication in the terms to differentiate if the defect in the patient is a central or peripheral defect. So if it's central, will be at the level of the hypothalamus. And if it's peripheral, it will be at the level of the pituitary and the gonads. So can differentiate the diagnosis between central and peripheral precocious puberty. But the most common use of the gonadotropin releasing hormone agonists are mainly to promote suppression of the gonadotropin release. Occasionally, they can be used as well for stimulation, as we're going to see in the next slide. So the main use is for suppression, meaning that as you know, when there is a sustained non-pulsatile administration of the gonadorelin or gonadotrophin releasing hormone, there will be, in this case, a suppression of further release of those hormones. Why? Because what stimulates the release is a pulsatile stimulus. And when you have a continuous non-pulsatile administration, then you have an effect of suppression. And by suppressing the gonadorelin, which is the other name for gonadotrophin releasing hormone, by suppressing the release of gonadotropins, there will be indication for the prostate cancer, for central precocious puberty, and also to control ovarian stimulation by assisted reproductive methods. We're going to mention that later on when we cover contraceptives. Also indication in endometriosis and advanced breast and ovarian cancer and early pubertal transgender adolescents. So precocious puberty means that the neurons that are releasing the gonadotropin releasing hormone are escaping from an inhibition of the central nervous system, and they initiate this pulsatile secretion of the hormone, which will stimulate the secretion of the gonadotropins and the gonadosteroids, and then that will direct to the development of secondary sexual characteristics appropriate for each sex, and which normally only occurs in girls the age after 8 years old and in boys later than 9 years old. So anything before that will be what we call precocious puberty. So gonadorelin could also be used in a pulsatile fashion, and to do that pulsatile fashion, there is a need of a programmable pump in order to deliver the hormone every 90 minutes intravenously, and that could be used to treat female infertility as well as male infertility. But that's not the most common use. Like I mentioned, the most common use is a non-pulsatile delivery, and is to produce suppression and not stimulation. So normally it's preferred to give a gonadorelin analog instead of the gonadorelin itself. And as we see here, the gonadorelin or the gonadotrophin releasing hormone is normally given intravenously or subcutaneously. But then the other analogs like leuprolide, goserelin, nafarelin, and triptorelin They are available in different sort of formulations, like for example, goserelin is an implant, subcutaneous implant. You also have a nasal spray and an intramuscular G-pod injection. But the uses for all of them are basically the same, which is prostate cancer, endometriosis, and to treat the central precocious puberty. In terms of adverse effects, we see here on the last column, the most important ones will be hot flashes, decreased bone density, and in both this you will see in both sexes, but in women you will see vaginal dryness, atrophy, and in men you will see erectile dysfunction. And those gonadorelin analogs are contraindicated in pregnant women. We also have the gonadorelin antagonists, and basically we have two groups. A group that has effect in women, preventing premature follicular luteinization, and that is done by suppressing the luteinizing hormone surge, and that will be ganirelix or cetorelix. And the one that is used in men, which is abarelix, and has the effect of extended release form of the gonadorelin antagonist. And indications basically for prostate cancer patients. In terms of side effects, hot flashes, weight gain, and increases in transaminase and gamma glutamyl transaminase. Also some effects on the heart, prolonging the QT interval, and a decreased bone mineral density. Okay, so what are the uses of gonadotrophin hormones, which are those three? The LH, the FSH, and the HCG. Basically, they are used to treat infertility by stimulating spermatogenesis in men or inducing follicle development and ovulation in women. The HCG, which mimics the action of the LH, is frequently used and is present in those tests that are used for the diagnosis of pregnancy, because the levels of those hormones can be detected very early during the pregnancy. We also have the menotropins, also known as HMG, which is basically a half and half mix of LH and FSH. We also have the FSH, folitropin alpha and beta, and then LH, which is a lutropin alpha. They are available for injection, subcutaneous injection. They only have been approved for the use in combination for the stimulation of the follicular development in an infertile hypogonadotropic hypogonadal woman that has a profound LH deficiency. Lutropin alpha with folitropin alpha may also be of benefit for certain groups of women that are normal gonadotrophic and not hypogonadotropic. Okay, so now let's move to look into the menstrual cycle for us to understand the use of the contraceptives. So we have here on the top the changes in the ovarian cycle, where you see the ovule that starts to mature, the growing follicle, and then finally the ovulation that occurs 14 days halfway of the menstrual cycle. That determines a change into corpus luteum and finally into corpus albicans. The temperature of the body changes during the menstrual cycle as well. It starts off in the low 36, and during ovulation, it hits a peak on 37. It stays high for the luteal phase, and then goes down around the 28 days. We also see the changes in the anterior pituitary hormones, where we see that LH and FSH has a sort of a maintenance level during the follicular phase, and the peak of the follicle stimulating hormone determines also the peak of the LH hormone, which is preceded by the peak of estradiol, that will lead to a follow in the levels of estradiol that now is increase the levels of progesterone. That is the hormone that is present during the luteal phase. And the changes in the uterine cycle here at the bottom, where we see in the follicular phase, after the menses, the uterus is mucosa is being restored, and then there is a development period during the luteal phase, and finally get ready for, if there's no nidation of the follicle, there is again the menses. So the FSH will be stimulating the follicle development, like the name says, and will stimulate the estradiol secretion as well in that first part of the follicular phase. The LH stimulates the estradiol and also stimulates the progesterone secretion by the corpus luteum, and will be responsible for prolonging the lifespan of the corpus luteum. And it's important to notice that the high level of LH, which we'll call LH surge, causes the ovulation and the luteinization. Okay, so how the estrogens have their mechanism of action? So estrogens are hormones, so they are lipophilic, so they are capable to cross the membrane of the target tissue and go into the cytoplasm and translocate into the nucleus and bind to their receptors inside the nucleus of the target cell. Here is showing the hepatocyte. So we see that there is a binding of the hormone, androgen or estrogen, forming dimers that are ER alpha or ER beta. And those dimers will be responsible for regulating the transcription, what we call the ERE, which are the estrogen response elements in the nucleus. And that is due to complex interactions with various co-regulators that are responsible for some of the tissue-specific effects. You're going to notice throughout the lecture that I'm going to be referring to estradiol as E2. That is because there are three major estrogens. E1, which is known as estrone, which is found in big amounts during the postmenopausal women period. The E2, which is the estradiol, which is the main estrogen found in a woman's body during the reproductive years. And we have the E3, which is the estriol, which is made in large quantities during the pregnancy. So estrogen adverse effects and contraindications. So in terms of adverse effects, it's important to highlight the postmenopausal uterine bleeding. It's possible, but is controversial, that they might promote cancer if using prolonged therapy. They increase the risk of endometrial carcinoma and hyperpigmentation. In terms of contraindications, of course, if you already have a tumor that is dependent on estrogen, it's contraindicated in that case. Patients that have a high risk of carcinoma of the breast, when you see an undiagnosed genital bleeding, in case of liver disease, of thromboembolic disorders, and should also be avoided by heavy smokers. Okay, let's start off with the first group of estrogen type drugs, which are the selective estrogen receptor modulators. So when we say modulators, it's because the drug might have agonistic effects and antagonic effects. So, for example, the two main ones that we are highlighting are tamoxifen and raloxifen. So, those drugs doesn't have a steroidal molecule, but they are considered partial agonists of the estrogen receptor, like we see here on the right hand side. And because they are partial agonists and not a pure agonist, like the estrogen, like estradiol, they will promote different changes in the transcription of specific genes. So they bind to the drug and causes changes that are different from those that are caused by estradiol, like it shows here on the right hand side. Tamoxifen main use is the primary hormonal treatment for metastatic ER plus PR plus breast cancer in premenopause, and also adjuvant therapy to reduce the risk of breast cancer recurrence. So as you see here, tamoxifen has an antagonic effect on the estrogen receptor that are present in the breast, but they have an agonistic effect on the receptor, the estrogen receptor, that are present in the bone and in endometrium. And because of that, they are helpful for osteoporosis, and they also increase the risk of endometrial cancer. And like estrogen, they also produce beneficial changes in the lipids, which is the decrease in the low density lipoprotein, which is the bad cholesterol. Haloxifen is also an antagonistic effect on the receptor that are in the breast, but in the breast and endometrium. So tamoxifen is only in the breast, and raloxifen is in the breast and endometrium, and has an agonistic effect in the bone. And that is mainly its indication to treat osteoporosis. It's also used to treat breast cancer prophylaxis and the treatment of fibroid tumors. What are the adverse effects and contraindications? Well, the main adverse effect will be hot flashes. They might have a tumor growth flare at the beginning of the therapy, but with time that will change for the main indication. Promotes increased risk of thromboembolism So it's totally contraindicated in women that are at risk of thromboembolism, and they also promote an increased risk of endometrial cancer, for tamoxifen specifically. We also have a group of drugs that is known as selective estrogen receptor degraders. And then the main representative will be fulvestrant, which is basically full estrogen receptor antagonist. So they will be used for hormonal treatment of ER plus breast cancer in postmenopausal women. And here I'll make a note that you can see it down here to remind you about your pathology lectures, that up 2/3 of the invasive breast cancer are classified as hormone receptor positive, or ER plus, PR plus, which means that they have estrogen receptor positive and progesterone receptor positive tumor. They also are classified according with the expression of the HER2, and then they can be either HER2 plus or HER2 minus if they do not express that gene. But those fulvestrant is a pure antagonist, so has no estrogenic effects, binds to the ER and causes degradation, like we see here. Binds to the estrogen receptor and degrades it. Is well tolerated, but can promote elevated liver enzymes. Another example of selective estrogen receptor modulator is clomiphene. And as we see here on the right-hand side, clomiphene is a partial agonist at the ER receptor, the estrogen receptor. So by doing that, it's kind of block or inhibit the gonada to release more LH and FSH that will stimulate the follicle to promote to secrete estradiol. So it's used for anovulatory infertility, and also, as you can see, it kind of blocks the negative effect, feedback of FSH and LH. It's blocking this negative effect. So FSH will rise, causing follicle development and maturation. So that's why it's indicated for anovulatory infertility. Also, if you stop clomiphene, it will unblock the estrogen bound to the receptor and promote stimulation that will cause an LH surge that we know is a determinant for ovulation. Adverse effects of clomiphene: multiple pregnancies, hot flashes, ovarian enlargement, and visual disturbances. I'll make a note here because some of you might be studying, following the first aid book, but there is this conflicting information from our book, our test book, with respect to this topic, because first aid says that clomiphene blocks the negative feedback at the level of the hypothalamus and not at the level of pituitary, like we mentioned in our slides. Anti-estrogens. So they're going to be doing the opposite effect of the estrogens. Basically, we have the estrogen synthesis inhibitors, or also known as aromatase inhibitors. So, and there will be two types. One that is reversible, which is non-steroidal or type 2. And the example will be anastrozole and letrozole. And you also have a group that is steroidal in nature, and because of that, they are considered type 1, and they bind irreversibly to the aromatase. And that will be exemestane and formestane. Both groups are indicated in the treatment of breast cancer or as a second-line treatment after tamoxifen. They lack the beneficial effect of tamoxifen on the bone density, and because of that, they should be administered with biphosphonates. And now let's talk a little bit about progestins, which are drugs that act like progesterone. They will bind to the two types of receptor for progesterone that we have, which is PRA and PRB. Because they have difference in the chemical structure, they will have a different ability to stimulate those receptors. So they can present different potency in terms of progestogenic and androgenic activity. They are chemically designed to increase the half-lives compared with the progesterone by bypassing the hepatic metabolism. The main pharmacological goal will be to minimize the androgenic and maximize the progestogenic activity. There are three series of progestins: the pregnans, the estrans, and the gonans, as we see here on the right-hand side. Pregnans, estrans, and gonans. So what are the physiological and pharmacological actions of progestins? Well, we know that progesterone is produced during the luteal phase, and that promotes a decrease in the gonadal release hormone pulse frequency, kind of resetting the hypothalamic pituitary axis back to the follicular phase. That is the main mechanism of action of progestin-containing contraceptives. It's exactly to promote this resetting of the HP axis back to the follicular phase. Progesterone suppresses menstruation and uterine contractility. It also changes the endocervical secretion into a sticky material, decreasing the penetration of the cervix by the sperm. They also promote development of a mammary gland that requires estrogen and progesterone, which could be, for example, actually a reason for the increased risk of breast cancer associated with estrogen progestin use in postmenopausal women. In terms of metabolic effects, progestin increases the insulin basal levels, increases the bad cholesterol, and reduces the effects of aldosterone in the renal tubule. Okay, so let's start talking a little bit about contraceptives. So oral contraceptives, we have mainly two types. It's either a combination of estrogen and progestins, or it could be contraceptives that are progestin-based only. The ones that are combination, the most popular are the monophasic, means that you have a constant dose of both components during the whole cycle. But we also have biphasic and triphasic, meaning that there will be changes in the concentration of both components once or twice during the cycle. So, what are the effects of oral contraceptives? They reduce that the reduction in the dose of the constituents of oral contraceptives made them markedly reduce mild and severe adverse effects. So, since the development of oral contraceptives to our days, there was a reduction on the dose during the evolution of the development of the contraceptives, which made them much more safe and convenient method of contraception. For example, they actually have beneficial effects, like they reduce the risk of ovarian cysts, as well as of endometrial cancer and benign breast disease. They promote a lower incidence of ectopic pregnancy, and the problem with iron deficiency and rheumatoid arthritis are less common, as well as premenstrual symptoms such as dysmenorrhea, endometriosis, acne, and hirsutism that are ameliorated with their use. So there are lots of beneficial effects nowadays that comes with the use of the oral contraceptives. Here's a table just for your information. Not going to be asking that, but just for you to have a sense of the size of the dose of the estrogen nowadays. So it's really small, like 0.02, 0.05, the highest going to 0.035. So it's really trying to mimic the normal amount that the body releases during the menstrual cycle. What is the mechanism of action of giving estrogen plus progesterone to avoid contraception? So as we see here on the right hand side, by giving estrogen and progesterone, the both hormones are acting with a negative feedback by promoting a reduction in the release of the gonadal releasing hormone by progesterone and reducing the secretion of LH and FSH by estrogen. So by doing that, they are capable to promote, have an action contraception effect. So estrogen and progesterone inhibit the ovulation by inhibiting the release of FSH and LH. If you don't have FSH, the follicle will not grow and there will be no release of E2. And if you block the surge of LH, there will be no ovulation. So it's a very effective mechanism of action. And also, progesterone has also the effect of increase the cervical mucus thickness, making the motility of the sperm harder, and also to decrease the endometrial growth, making the environment less hospitable for the ovule implantation. So we mentioned before, and I'm going to emphasize here, the benefits of monophasic pills. Some women experience fewer side effects because they promote a steady level of hormones during the whole cycle. They also, there is a lighter period with fewer cramps and has been shown to be reduced risk of acne as well as of development of certain types of cancer. In terms of adverse effects, important to remember is venous thromboembolism. So it's going to be totally contraindicated in women that are at risk of thromboembolism, especially in women that are smokers over the age of 35, and should not be used in women that are over 35 and smoke. That is a double no-no. Also hypertension, biliary disease, and potential stimulation of growth of existing reproductive cancers. Another important adverse effect is a breakthrough bleeding, which is more common with low dose of estrogen formulation. Breast tenderness, enlargement, nausea, vomiting, headache, migraine, especially also migraine with aura, which actually may indicate some sort of a cerebral ischemia or a stroke. Melasma, inhibition of lactation, fluid retention, so that can lead to weight gain. Acne, like we mentioned, and some women also exhibit psychological changes like depression, anxiety, and libido changes. So, what we should do when the problem is related with estrogen in the preparation, which the adverse effect mainly will be nausea, mastalgia, breakthrough bleeding, and edema. In that case, you should shift to a preparation that contains smaller amounts of estrogen or more androgenic effects. If you're using a combination preparation that normally promotes withdrawal bleeding, sometimes that fails to occur, what you can do is to move to a different preparation or try other methods. If you're using a preparation that is progestin agent alone, which the most common side effect is breakthrough bleeding, then you can switch to a biphasic, a phasic, or a triphasic oral contraceptives. Try to decrease this breakthrough bleeding. If you are using combination of androgen-like progestins, and the main adverse effect will be weight gain, you should shift to a preparation with less progestin. And if you are having a lot of problems with acne, you should use estrogen to improve. And if you are using a method that uses estrane, which is the main side effect will be hirsutism, you should switch to non-androgenic progestins. So basically the contraindications are women with 35-year-olds or higher than 35-year-olds. There are shown to be, and if they are heavy smokers as well, there is a total contraindication due to the risk of cardiovascular events. Cardiovascular disease will be a contraindication as well, especially if there is history of thromboembolism, coronary artery disease, myocardial infarction, or stroke. Women that has hormone-responsive cancer, especially in the breast, or that has significant hepatic disease. And of course, is teratogenic if given to pregnant women. In terms of interactions, important to call attention of the use of some classes of antibiotics like sulfonamides, tetracycline, cephalosporin, penicillins, erythromycin, and metronidazole. It looks like there is an interruption of the enteropathic cycling of ethinylestradiol when you reduce the bacterial population in the small intestine, which seems to be the reason of this interaction with antibiotics. The inhibition of hydrolysis can also lead to increased fecal loss of the hormone, which can result in lower circulating levels of ethinylestradiol. Other important groups of drugs for interactions with the oral contraceptives will be anti-tuberculosis drugs like rifampin isoniazide and antifungal like fluconazole and ketoconazole. When you use progestin-only contraceptives, the mechanism of action is mainly due to the thickening of the cervical mucus and the endometrial alterations that decreases the sperm penetration and impair the ovule implantation. So you will see progestin as part of the the intrauterine devices, like we see here on the right hand side. Could be given as an intramuscular injection. Could be also subdermal implants that can last up to 5 years, or could be also what we call the mini pill, which low doses of progestin every day. Low doses of progestin or mini pill are indicated in breastfeeding women because they can produce less disruption of the lactation and help to treat the endometriosis. Subdermal implants, depot injection, like we mentioned, intrauterine devices, and is also part of the formula of the what we call Plan B, which is an emergency contraception pill. So the mini pill or the depot injection, the mechanism of action will be to suppress the luteinizing surge, and by doing that, we'll block the ovulation. We'll also alter the cervical mucus and endometrium development. Being used in an intrauterine device, it will promote also a local effect on the uterus. And also, like we mentioned, emergency contraceptive, and the main action will be to inhibit or delay the ovulation. Important to remember that those cannot cause, does not cause an already implanted embryo to dislodge. Right? So if there's already, the embryo is already implanted, that's not going to be of no good. In terms of adverse effects, oral or injected will be similar to oral contraceptives, thromboembolism, stimulation of existing reproductive cancer growth, and so forth. In a EUD, a lower risk of systemic effects, but there is an increased risk of ectopic pregnancy and infection, which in many cases is the reason of the removal of the IUD. An emergency contraceptive basically will be nausea, vomiting, and painful cramps. There are also pills that are given after the coitus, and they are known as postcoital contraceptives, and the pregnancy will be prevented by giving estrogens alone or progestin alone or in combination. So, for example, what we know as morning after contraception, which is a treatment that has to be done within 72 hours of the coitus, and normally is effective 99% of the time. Many times it's administered with antiemetics, since the major complaint is nausea and vomiting. So here are examples of postcoital contraceptives: conjugated estrogens, estrogen alone, progestin alone, and we're going to highlight here mifepristone, which is given with misoprostol, which is a PGE1 analog. And we are highlighting here mifepristone is a postcoital contraceptive. Mechanism of action will be competitive antagonist on progesterone receptors. Like I mentioned, is given association with misoprostol that will stimulate the uterine contractions to expel the embryo. The adverse effects mainly will be uterine cramping and heavy uterine bleeding. Another anti-progestin contraceptive is ulipristal that has been licensed in the United States and the European Union as an emergency contraceptive, is a partial agonist of the progesterone receptor, as opposed to mifepristone, which is a competitive antagonist. Okay, so ulipristal is a partial agonist, and by doing that, has different effects if given in different phases of the menstrual cycle. If it's given mid-follicular phase, will inhibit the follicle genesis. If given at the LH surge, it will delay ovulation. And if given during the luteal phase, will decrease the endometrial thickness, making the environment for the embryo nidation difficult. Adverse effects: headache, nausea, irregularities in the menstrual cycle. Okay, another use of the estrogens will be as a hormone replacement therapy to alleviate the menopause symptoms, which are basically hot flashes, vaginal atrophy, sleep disturbances, and mood changes. They also have the effect to reduce the risk of osteoporosis, like we mentioned before. And basically, even if you're giving conjugated estrogens, or in combination as well with medroxyprogesterone. The mechanism will be they'll be replacing estradiol and progesterone that are not being produced by the ovaries anymore. The estrogens will release the menopausal symptoms, and the progestins, along with the estrogen, will decrease the risk of endometrial cancer as well. Estrogen-only formulations, we have given orally conjugated estrogens. You have transdermal preparations, but it's important to remember that can only be given to women with prior hysterectomy, because estrogen alone increases the risk of endometrial cancer. So women with the hysterectomy do not need to receive progestin, but you might need to add to decrease that risk when you're giving estrogen as a hormone replacement therapy. They are available in the form of creams and gels. When their only symptom is vaginal atrophy. You can also give a formula that has continuous estrogen and progestin, and here are some examples. Orally, transdermal, and also continuous estrogen with cyclic progestin that causes breakthrough bleeding and is generally not very acceptable to women. Adverse effects. Long-term effects are under study, but one thing is very well known is the decreased risk of osteoporosis and fracture, which is a good thing. Contraindicated in women with history of thromboembolic disease, myocardial infarction and stroke, severe hepatic disease, and hormone-sensitive cancer. So you see those adverse effects that keep coming back over and over again every time you talk about estrogens. And finally, to close up this lecture, let's talk a little bit about agents affecting the uterine motility, which are the uterine relaxants, cervical ripening agents, and uterine stimulants. Uterine relaxants, also known as tocolytics, they are given in the preterm labor only to delay for 24 or 48 hours, and normally give corticosteroid to induce lung maturity in the fetus. Example is terbutaline, which is a beta-2 adrenal receptor agonist, right? It will inhibit the myometrial contraction. And as adverse effects, you have the cardiac stimulation, right? Because it's not a beta 2 specific. Will also promote hypertension and hyperglycemia. Another drug that we know, which is a calcium channel blocker, nifedipine, also decreases the myometrial contraction. Adverse effects will be hypertension. And indomethacin, which is a non-steroidal anti-inflammatory drug that has a non-selective COX inhibitor that will promote inhibition by elevation of the PG production in the labor. Cervical ripening agents, prostaglandins, and the main example is misoprostol, PGE1 analog. That what it does is to cause the collagen in the cervix to dissolve and the cervix to soften, and that will be able to respond better to the labor induction. Adverse effects, uterine taxistole and diarrhea is very common. Contraindication, women with prior uterine surgeries. And uterine stimulants, oxytocin, will increase the amplitude and frequency of uterine contractions, causing the cervix dilation and labor induction. Can be used also to treat postpartum hemorrhage by contracting the uterine muscle. And in terms of contraindication, will be prior classical cesarean or C-section or other uterine surgery. And finally, a group of drugs that has been more utilized in the latest years, which is the gender-affirming feminizing therapy, which is the use of estrogens to help the transgender to the man to develop feminine body features to match the gender identity. Okay? So by giving that, what will happen is going to be a delay in the puberty, suppress androgen production by giving supplemental estrogen and progestins. So the mechanism by delaying the puberty is because if you give agonists of the gonadotropin releasing hormone, what's going to happen? If you provide a continuous continuous infusion, right, dosing of those gonadotropin agonists, that will promote a blockade of the release of LH and FSH, and consequently the production of testosterone. So with less LH produced, there will be less testosterone produced. And that's the idea of using this kind of drug for affirming feminizing therapy. Same thing can be done with medroxyprogesterone. We have the same effect, decreasing FSH and LH production. Suppressing androgen function and effects by, like I mentioned, giving the continuous gonadotropin agonist receptor, and also aldosterone antagonists, like for example spironolactone, that has an androgen receptor blocking activity. And also there is another drug which is a non-steroidal androgen receptor antagonist, flutamide, that is also used with that purpose, because it blocks the binding of the androgen with the receptor. So by providing supplemental estrogen, either by oral patch or depot injection, the estrogen discontinuation, if that happens, in trans woman who has had her testes removed will result in increased risk of osteoporosis. Thromboembolism in trans women is also higher than in cis men. And higher doses of supplemental estrogen does not provide faster or greater results than the physiological dose, but does increase the risk of adverse effects. And this is our drug list.